Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 353 of our pharmacotherapy series, which majors in asthma. The next case reads, SHT, a 45-year-old, 91 kilograms man with a long history of severe persistent asthma, presents to the accident and emergency department with severe dyspnea and wheezing. He is able to say only 2 or 3 words without taking a breath. He has been taking 4 inhalations of beclomethasone hydrofluoroalkane, abbreviated as HFA, 80 micrograms per puff, twice daily, and 2 inhalations of albuterol metered dose inhaler 4 times a day as needed on a chronic basis. SHT ran out of beclomethasone a week ago. Since then, he has been using his albuterol metered dose inhaler with increasing frequency up to every 3 hours on the day before admission. He is a lifelong non-smoker. His forced expiratory volume in 1 second was 25% of the predicted value for his age and height, and his arterial oxygen saturation was 82%. His vital signs are as follows. His heart rate was 130 beats per minute. He has a respiratory rate of 30 per minute. There was a pulsus paradoxus, 18 mm of mercury. His blood pressure was 130 systolic, 90 diastolic. His ABDs on room air were as follows. A pH of 7.40. His arterial oxygen pressure was 55 mm of mercury. Partial pressure of carbon dioxide was 40 mm of mercury. Serum electrolyte concentrations were as follows. Sodium levels of 140 milliequivalents per liter. Potassium levels of 3.9 milliequivalents per liter. And chloride levels of 105 milliequivalents per liter. Because of the severity of the obstruction, SHT was monitored with an electrocardiogram that showed sinus tachycardia with occasional premature ventricular contractions. Albuterol 5.0 mg and ipratropium 0.5 mg were administered by nebulization with minimal improvement. SHT then was started on oxygen at 4 liters per minute by nasal cannula, followed in 20 minutes by a second dose of albuterol 5.0 mg plus ipratropium 0.5 mg via nebulizer. Subsequently, SHT's heart rate increased to 140 beats per minute, and he complained of palpitations and shakiness. His peak expiratory flow was now 25% of personal best. His laboratory values were as follows. A pH of 7.39. Arterial oxygen pressure of 60 mm of mercury. Partial pressure of carbon dioxide of 42 mm of mercury. Sodium levels of 138 milliequivalents per liter. Potassium levels of 3.5 milliequivalents per liter. So my question to you is, what adverse effects experienced by SHT are consistent with systemic beta-2 agonist administration? SHT experienced palpitations, which may have been caused by the widening of his pulse pressure from vasodilation. Albuterol and all other beta agonists are cardiac stimulants that may cause tachycardia and, very rarely, arrhythmias. Because they are relatively beta-2 specific, the cardiac effects are more prominent with systemic administration, as opposed to inhalation, and at higher dosages. However, other causes of cardiac effects must also be considered, such as hypoxemia, which is also a potent stimulus for cardiac arrhythmias. Therefore, SHT's tachycardia may have been caused by the beta-2 agonist, by the worsening of his airway obstruction, as reflected in the increase in partial pressure of carbon dioxide, or by both of these variables. The decrease in the serum potassium concentration from 3.9 to 3.5 milliequivalents per liter could be attributed to beta-2 adrenergic activation of the sodium-potassium pump and subsequent transport of potassium intracellularly. However, at usual doses, aerosolized albuterol causes relatively little effect on serum potassium. The effects may be more noticeable with high doses of inhaled albuterol. A beta-2 adrenergic-mediated increase in glucose and insulin secretion also can contribute to the intracellular shift of potassium. The shakiness, that is tremors, experienced by SHT probably can be attributed to beta-2 receptor stimulation of skeletal muscle. Again, this effect is most prominent with oral or parenteral administration, but some patients are very sensitive to even small doses of inhaled short-acting inhaled beta-2 agonists. My next question reads, why did SHT fail to respond to the initial therapy? Could tolerance to the beta-2 agonists have contributed? Although tolerance to systemic effects of beta-2 agonists, e.g., tremor, or sleep disturbances, is documented, tolerance to the airway response does not occur to a clinically significant extent. Even with long-term use, the intensity of response to beta-2 agonists is retained, i.e., the maximal % increase in pulmonary function, but the duration of response with each dose may shorten. Such an effect is unlikely with intermittent use, but may occur in patients who routinely use large, multiple doses daily. Possible explanations for this variability include downregulation of receptors, disease progression, or true drug tolerance. The exact contribution of each is not known. Therefore, SHT's failure to respond to the initial therapy most likely is attributable to the severity of his airway obstruction. SHT's history of severe chronic asthma, the slow progression of this attack, and the lack of response to his inhaled beta-2 agonist also are largely owing to a significant inflammatory component to this attack. Thus, bronchodilators would not be expected to immediately reverse the airway obstruction in SHT. It would be difficult to attribute his lack of initial response to therapy to beta-2 adrenergic subsensitivity. In addition, it is not likely that beta-2 adrenergic receptor polymorphisms could account for SHT's initial lack of response. Although polymorphic variations are documented to be relevant in some stable patients, further study is needed to establish clinical relevance. Repeat measurements of peak expiratory flow and AB-GIS indicate continued significant bronchial obstruction. So my question to you reads, what should be the next step in SHT's therapy? SHT received initial therapy with a combination of inhaled short-acting inhaled beta-2 agonists and ipratropium. He should receive a third dose of albuterol 5.0 mg plus ipratropium 0.5 mg 20 minutes after the second dose. Because of the severity of his exacerbation, he should then receive albuterol 15 mg per hour by continuous nebulization, with close monitoring of his cardiac status. SHT's peak expiratory flow also should be monitored. My next question to you reads, are systemic corticosteroids appropriate for SHT? When can a response be expected? Corticosteroids have potent anti-inflammatory activity and are definitely indicated in SHT in patients like SHT with acute asthma. Corticosteroids decrease airway inflammation and increase the response to beta-2 selective agonists. Corticosteroids are not smooth muscle relaxants, i.e., not bronchodilators. However, they can relieve bronchial obstruction by improving the responsiveness of beta-2 receptors and by inhibiting numerous phases of the inflammatory response, e.g., cytokine production, neutrophil and eosinophil chemotaxis and migration, and release of inflammatory mediators. The anti-inflammatory activity of corticosteroids is delayed for about 4 to 6 hours after the dose has been administered. Corticosteroid-induced restoration of responsiveness to endogenous catecholamines and exogenous beta-2 agonists, however, occurs within 1 hour of administration of the corticosteroid in severe, chronic, stable asthmatic patients. Significant improvement in objective measures, e.g., forced expiratory volume in 1 second, generally occurs 12 hours after administration. Consequently, EPR3 advocates early initiation of corticosteroids in cases of acute severe asthma. Corticosteroids also hasten the recovery of acute exacerbations of asthma and decrease the need for hospitalization if given early in the initial management of acute asthma in the accident and emergency department. On the basis of his initial presentation, SHT should be started on systemic corticosteroid therapy immediately in the accident and emergency department. Preferably, oral corticosteroids would have been started at home before SHT's exacerbation escalated to this degree of severity. The next question reads, what would be an appropriate dosing regimen of corticosteroids for SHT in the accident and emergency department? Would the dose and route be the same if he were hospitalized? Doses of corticosteroids used to treat acute asthma are largely empiric. Studies comparing very high dosages, e.g., intravenous methylprednisolone 125 mg every 6 hours in an adult, versus moderate dosages, that is 40 mg every 6 hours, have shown no advantage with very high dosages. In addition, oral therapy is as efficacious as the IV route. Dosing recommendations for systemic corticosteroids in the management of asthma exacerbations in the accident and emergency department or hospital are listed in EPR3. Higher corticosteroid dosages may be considered in patients with impending respiratory failure. When patients cannot take oral medication, IV methylprednisolone is preferred over hydrocortisone in patients with heart disease or fluid retention or when high dosages of corticosteroids are used. This is because it has less mineralocorticoid activity. For patients who require IV corticosteroid therapy, the dosage can usually be reduced rapidly to 60 to 80 mg per day for adults, or 1 to 2 mg per kilogram per day for children, because the condition improves, usually after 48 to 72 hours. On discharge from the hospital, EPR3 recommends, for example, prednisone 40 to 80 mg per day in 1 or 2 doses for 3 to 10 days. Although some clinicians may prescribe a tapering regimen, no taper is necessary in this situation. On the other hand, If the patient required long-term oral corticosteroid therapy before hospitalization, tapering the dose to the pre-admission dosage is prudent. For patients who are discharged from the accident and emergency department, up to 7 days of prednisone therapy usually is sufficient. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 354.